Sepsis Awareness Inpatient Pathway at the Bradgate Mental Health Unit. The aim of this session is to promote an awareness and confidence in using the sepsis recognition flowchart within the Bradgate Mental Health Unit. Objectives: to support an awareness of the sepsis recognition flowchart, to develop confidence and knowledge of staff in the early recognition and management of sepsis. What is sepsis? Sepsis is a life-threatening condition. Sepsis leads to shock, multiple organ failure and death, especially if not recognised early and treated promptly. Sepsis can be caused by any type of infection: bacterial, viral, fungal, or even parasitic. Sepsis is a life-threatening condition and arises when the body's response to an infection injures its own tissues and organs. It is the body's overwhelming response to infection. It becomes overwhelmed due to the infection. We all react differently to the same infection, so not everyone will have that overwhelming response. Sepsis can be caused by a huge variety of different bugs, but most cases are caused by common bacteria which we all come into contact with every day without them making us ill. We look at the common causes later on. This is the new definition for sepsis: life-threatening organ dysfunction caused by a dysregulated host response to infection. This means that the body can't deal with infection and organs start to shut down. The body's own response to infection becomes very overwhelmed. This can lead to shock if not treated. The diagram shows that there has to be an infection present. Most of us will get better from that infection with a course of antibiotics and a period of rest. But sometimes, for some reason, the patient with a particular infection may have that overwhelming response, resulting in their organs beginning to dysfunction, which in itself is the start of sepsis. If sepsis is not treated promptly, this can develop to red flag sepsis, which can lead to shock and death, again, if not assessed and treated promptly. Why is sepsis important? Please now watch the short video. It's only 4 minutes long.
The doctor came out to see Jem on the Friday afternoon. It was around 12 o'clock. He had a look at him, the doctor, and he said, yes, you've got an infection. I'm going to give you some antibiotics. About 7 o'clock in the morning, Jem called me to go into the bedroom, and he said, I'm cold. And I said, okay, I'll go and get your water bottle. And I said, how do you feel? He said, well, I don't feel sick anymore. But I just noticed that his lips were very blue and cracked. Still didn't think it was anything bad. Still didn't think it was meningitis or sepsis, because I didn't even know what sepsis was. So I thought, he must be really dehydrated. So I thought, I'm going to have to ring for an ambulance. I'd never ever phoned for an ambulance before in my whole life. I even apologised to them on the telephone. I said, I'm really sorry for wasting your time. I said, my husband's had an operation, and I said, I think he's dehydrated. I said, he needs to go into hospital. And they said, okay, we'll be around as soon as we can.
Jem was one of the first patients I treated as a newly appointed consultant. But what I remember most clearly was how Jem looked. I could tell Jem was near death. His skin was pale, his skin was mottled, his lips had a bluish discoloration. It was very clear from the outset that Jem was very, very likely to die.
And about 5 minutes later, a lady doctor came in and said, his heart has stopped. We're doing all that we can. And we just looked at each other and I just began to cry then, because I thought, no, he's dehydrated. You know, why does his heart need to stop?
So that day, I took Karen to the relatives' room to speak to her about this terrible illness that was about to claim her husband's life. And that she was going to have to go home and tell their 2 young children that Daddy wasn't coming home.
But then they said he's going to be brain damaged, and I said, how brain damaged? And they said he probably wouldn't recognise the children. As I said, the decision was made to turn the machine off. So at 4:10 on the Tuesday, the nurses unplugged the machine. They took the bleeping noise off so that we didn't have a countdown. And then when he died, they just came into the room and just said, he's gone.
Sepsis is dangerous for 2 reasons. It's dangerous because of the speed with which it progresses, and it's dangerous because it's often not picked up quickly enough.
It was just awful. It was just the most horrible thing to have to go through, and I just don't want other families to have to go through that if they don't have to. And that's why I do want to make a difference. I want to make a change. I'm passionate about it, and I want to make a change. I want to raise awareness. I want people to know what sepsis is and how dangerous it is and how severe it is. You know, 37,000 people die from sepsis in this country a year. And if I can do my little bit, if I can help, then that's what I want to do.
The gentleman mentioned in the video only actually had a vasectomy. This was a short day case operation. Sadly, he passed away due to a post-op infection despite having been seen by the GP prior to becoming very unwell. He was treated with a routine infection as any of us would be. Emphasis on this is safety netting. If someone has antibiotics, we need to check that they are starting to feel better, that they are working and they are continuing to work. We need to continue to monitor their vital signs and check with them how they're getting on. Ask the patient to report to us if they start to feel worse. If our patient is vulnerable and unlikely to report concerns, our role is to support them by monitoring them. During their admission to the Bradgate Mental Health Unit, we are expected to carry out daily news following the 72-hour period, in which time it is twice daily. This will allow us to support and monitor those that cannot do so themselves and detect any changes or deterioration as early as possible. This is extremely important as they are currently under our care in a healthcare setting. Why is sepsis important? This slide just reiterates what we've just learnt from the video, that sepsis is a life-threatening condition and appears rapidly in any speciality. Every 3.5 seconds, someone somewhere in the world dies from sepsis, and more people die from sepsis than breast and bowel cancer combined. We now know that simple, evidence-based interventions are available and can save lives. This is talking about and referring to the Sepsis 6 bundle and our prompt action in detecting a patient with sepsis. We know that prompt and effective treatment can also reduce mortality by up to 50%. We'll now look at some of the high-risk groups. Now, although the very young and the very old are not in our area, this is referring to people below the age of 1 year of age and above the age of 75. We know that any age group can develop sepsis, and any age group can have an infection. There have been media reports of young teenagers that have passed away, sadly, due to infections, so it is very relevant to our area. Any breach in skin integrity. A patient with any kind of skin wound, cut, burn, self-harm wound, somebody that's at risk of increased picking or scratching, pressure ulcers, these are all patients that will have an increased risk. People with an indwelling catheter. Catheters are known to be a high-risk category. IV drug users are also at high risk due to the injection sites and the risk of infection through dirty needles. Those with chronic illness. This can include patients with complex comorbidities such as diabetes, COPD, respiratory diseases, on top of their mental illness. We know that our patients do not just present with one illness anymore, and this is going to become more evident in the future. Those with a weakened or impaired immunity. If you know your patient has recently had chemotherapy, or they have diabetes, or sickle cell, or a splenectomy, these are areas that they may be also on medication that increase their risk of having a lowered or weakened immunity. So these are patients to pay attention to. Think about what drugs they may be taking that could also impair their immunity. Early symptoms of sepsis may present as being non-specific and non-localised. The patient might not necessarily appear unwell or have any obvious signs or symptoms. Some people just don't feel right. It would always be worth checking someone's vital signs if they inform you that they don't feel okay, to help that you rule out a physical cause. The patient might just feel generally unwell. They may or may not have a temperature. If they did have a temperature, it would be significant if it's greater than 38 degrees or lower than 36 degrees Celsius. But sometimes a temperature may not be present. Chills and shivering may also be evident. This is known as rigors. They may experience a rapid heart rate and a change in mental state. We can acknowledge that within the area at the Bradgate Mental Health Unit, some of these are areas that are always triggering for your patient. This is why it's really important that you know your patient, that you know their baseline, and you know that something's not right. You'll be able to use this information and take it to the medic on the wards to discuss the problem and the concerns that you have. Evidence does indicate that sepsis is often not suspected or recognised. For some healthcare professionals, the care of a person with severe sepsis will be an unusual event, but their suspicion of the diagnosis and early recognition may be crucial for that person. This is where our role at the Bradgate Mental Health Unit is vital in the early detection and prevention of severe sepsis and red flag sepsis. So your patient is not well. What do you need to do? If you imagine a situation where you're doing a set of routine observations and you notice the patient doesn't look well, or they're shivering, or their mental state's altered. Perhaps their carer or their friend or family has told you that they don't look right, or a member of staff has come to you and asked you to raise concerns. If you haven't already done so, you could take a set of vital signs and score this on your news. At this point, we would ask you to look at your sepsis flowchart. Have a look at the questions in box 1. This is asking you if your patient is scoring a news score of 3 or above, a new or increased confusion, or looks unwell. You are looking for a score of 3 or more in total, and or a 3 in one parameter. This will be allowing for any variances and exceptions that you've already agreed via the MDT for that particular patient. It is at this point we are asking you, could this be sepsis? Think. If your patient has a news score of 3 or more at this point, think. Are they already on treatment for an infection, so they already have a known infection? Is that patient responding to the antibiotics? Think. Could you have a new or undiagnosed infection? Think. Do they have a new or altered mental state? If you're answering yes to any of these questions, you need to move down onto box 2 on the sepsis pathway. Ask yourself, can you think of some of the most common infections that lead to sepsis? These are outlined on box 2 of the pathway. Some of the suggested infections within the pathway are chest infection, urinary infections, cellulitis or necrotizing fasciitis, abdominal infections, bone or joint infections, meningitis, Any device-related infection, so that would include any catheters, any lines going in, any peg sites, and any other area that you think might be infected. If you don't know where the infection is, but you feel strongly that there is one, you can tick yes to this, but you can suggest that the source is unclear. NICE 2016 stated, think, could this be sepsis if a person presents with signs or symptoms that indicate possible infection? As suggested before, we are advised to be attentive to concerns expressed by the person, the family or carers, for example changes from unusual behaviour. Assess people who might have sepsis with extra care if they cannot give you a good history. For example, people with English as a second language or people with communication problems. Assess people with any suspected infection to identify possible source of infection, factors that increase risk of sepsis, any indications of clinical concern, such as a new onset abnormalities of behaviour, circulation or respiratory concerns. Going back to box 2 on the pathway, it outlines possible infections to think about. I'm just going to run through each of those infections and give you an idea of some examples of each. For those with a chest infection, consider those patients that may be in bed for long periods of time. They may be immobile. Those that have an aspiration risk, they're all at high risk of developing pneumonia. Patients with increased exposure to the risks of TB. Patients that may have been rough sleeping or had poor living conditions prior to admission. Patients with any long-term respiratory condition, may all have increased risks of developing a chest infection. Patients developing UTIs, this could be a result of dehydration or constipation, demonstrating the importance of the 72-hour monitoring sheets that you complete at the Bradgate unit. This will help you determine whether your patient is well at the point of admission when they are at their most vulnerable. Poor hygiene, catheters, patients that are sex workers are all at risk of developing UTIs. Symptoms may have been subtle and gone undetected and untreated. Cellulitis and skin infections could develop from self-harm wounds anywhere on the body. Any bites, any eczema. Think about broken skin. Has the patient got any breaks within their feet, athlete's foot? Think about those that may be diabetic or have diabetic feet. They would need an urgent referral. Patients with infected peg sites can also have skin infections. Any abdominal pains, any abdominal infections. This could be as a result of constipation, bowel obstruction, perforated ulcers and appendicitis. With regards to the risk of constipation and abdominal concerns resulting in infection, we are aware that the use of antipsychotics increase the risk of constipation. We've seen many cases within our area where patients have developed UTIs secondary to dehydration and or constipation, which is known as a high risk linked with the medication. You may have read about cases in the media in learning disability services and the death of a gentleman named Richard Hadley who had 10 kilograms of stool removed from his bowel prior to passing away, which has not been monitored due to not being monitored or detected by his carers. Another case was a gentleman by the name of Daniel Warburton in 2017. He was a gentleman with schizophrenia. The coroner's report has determined Daniel's death was caused by a condition called clozapine-induced gastrointestinal hypermobility, also known as slow gut. Again, this identifies the importance of us monitoring our patients and asking those personal questions about having your bowels open. It takes 2 seconds and you can record it that a patient has reported that they are okay. Patients with diabetic feet are at risk if they have any damage or breaks of the bone. Bacteria can invade the bone, leading to osteomyelitis. The most common cause of bone infections is Staphylococcus aureus bacteria. Device-related infections can include, as stated before, catheters, peg tubes. Anything that is going into the patient that is a foreign body is a risk of infection. Look out for patients that have returned from UHL that may have cannula sites that may have become infected. Sometimes the site is very tiny and sometimes the source of infection is unknown. As you can see, all the possible infections are possible for our patients at the Bradgate Mental Health Unit and within community services. Infections can affect a person's mental state, and a person may not be aware of their symptoms due to their mental state. This is where the daily news again is there to assist staff to detect the early deterioration of a patient's health. If you have said yes to any of the above infections in box 2, you need to move down into box 3 of your pathway. So if we recap here, you've done a set of vital signs on your patient. Their news score is 3 or above, or you're concerned that they are not well, or they have increased or new confusion. You've thought about whether they have an infection, and you've decided you think they do have an infection. You move down into box 3. At this point, you're looking at whether the patient has red flag sepsis. Red flag sepsis is a time-critical condition and immediate action is required. This would result in you calling 999 and 222 and contacting your ward medic for urgent response. If you have identified that they do have a current infection, the red flag system is presented as an ABCDE approach. For any one of these parameters, your patient would have to be scoring a 3 in one parameter alone, at least. This would indicate a red flag sepsis. In addition to that, if they are scoring for either any of the following, a new onset delirium, they're only responding to voice or pain, or they are unresponsive, or they have a rash that is mottled or ashen, or they are looking cyanotic, which is a blue tinge to the skin, or you're aware that they have neutropenia or chemotherapy within the last 6 weeks, these are automatically red flags for sepsis in the presence of a known or suspected infection. At this point, you are being asked to contact 999 and 222. Additional symptoms within red flag sepsis may include that the patient is feeling dizzy or lightheaded. They may feel like they're having nausea or vomiting. They may have diarrhea. They may be experiencing slurred speech. They may be having severe muscle pain or feel cold, clammy, pale, or have mottled skin. They may have loss of consciousness, all of which automatically you would be seeking immediate help. It is at this point that if you have identified any of those red flag parameters in conjunction with an infection, that your role within adult mental health inpatient areas is crucial to enable a timely detection of any suspected sepsis to be actioned, and that patient can then be sent to the Leicester Royal Infirmary for further assessment. If you have selected yes to any one of the parameters and you suspect or know that there is an infection, you need to move across to the high-risk sepsis box. So you've identified red flag sepsis. The pathway may appear slightly different when it is launched at the Bradgate Mental Health Unit. This basically is the area where you are being asked to contact 999 222 and contact the ward medic for urgent medical response. There will be an introduction of a black box within the Bradgate Mental Health Unit only. This is a black sepsis box. The box will be held either on a ward-to-ward basis or shared at either end of the unit. This information will be clarified at a later date when the boxes are launched. The box contains some crucial treatment for the patient to be commenced on as soon as possible. On the point of detecting red flag sepsis, the first hour is time critical for the patient to have the best outcomes. Ward medics will be expected to commence the Sepsis 6 bundle. They will rely on you obtaining the black box and supporting them through this process. The medic will be responsible in inserting a cannula, commencing some fluid and administering the first dose of IV antibiotics whilst waiting for the urgent response from the ambulance. Your response when calling the ambulance can be supported with the SBAR tool. You will be able to use the details you've obtained from the pathway to explain to them that this is red flag sepsis. You will be able to communicate the news score, the fact that the patient has a known or suspected infection, have red flags present. You can use the term red flag sepsis. The EMAS service is now alert to the fact that if using the term red flag sepsis, the response should be smooth and in line with that of someone being reported as having a cardiac event. Whilst the medic is managing the black box and supporting the patient to commence the sepsis 6 bundle, the medic will be expected to stay with the patient during this time, as there is no expectation that ward staff, healthcare support workers or qualified are expected to manage the fluid or the antibiotics or the cannula, as we are not trained to do so. It would also be beneficial to have the resource trolley available in the event that things deteriorate before the EMAS team arrive. Whilst the doctor is completing the Sepsis 6 box as much as they can before the EMAS team arrive, if a member of staff could support them to document the times that the medications or fluids were commenced, this can then follow the patient to UHL, as the pathway is in line with the forms that they use there. The EMAS team will then take over the care of the patient. Communicate to them all the information you have using your SBAR tool. When the patient has left the unit, don't forget to complete an EIRF form on your safeguarding system. Please specify that this was a suspected sepsis event and what actions were taken. Please ensure you document this on Rio also. It's really important also that you stay with your patient until they are transferred and send the pathway with them, but keep a copy for your own Rio records. This will all happen quite quickly. In a step-by-step process it sounds longer, however you'll be flowing through the flowchart naturally whilst you carry out the news and make those clinical decisions. Going back to slide 15, where we talked about red flag sepsis. If you've got to this point and you answer no here, that there are no red flag sepsis indicators, the pathway guides you back up to the amber box, shown on slide 18, as a moderate risk of sepsis. At this point, we have determined that the patient is scoring a NEWS of 3 or more or above, they're feeling unwell, or they have a new confusion. You've gone down to box 2 and you have clarified that you are strongly in suspicion or are aware that the patient has an infection present. You've gone down to box 3 and ruled out that they do not have any red flag indicators. At this point, you have to follow your directions within the moderate risk of sepsis box. This is supported strongly with the news triggers. This will guide you into your actions, and at this point you would be guided to call for urgent medical attention, requesting that the patient is to be seen within the next 20 minutes. The moderate risk of sepsis box indicates that the medic will come to view the patient. If at this point they clinically decide that they would like to start the Sepsis 6 bundle, the actions are as previously discussed if you were identifying a red flag sepsis. At this point, the patient would still need to be transferred to UHL, as we do not have the facilities to continue the monitoring and administration of the medication that might be required for this patient. So although this is not red flag sepsis, the medic is trying to catch and prevent this sepsis that is likely before it develops into red flag sepsis. You would be able to contact 999 and explain to them, using your SBAR tool, that the patient has scored on the news. They have a likely infection and it is likely that sepsis is present. The medic has commenced the Sepsis 6 bundle and the patient needs to be transferred to UHL. You can identify to them that at this point there currently is no red flag indicators. You would then stay with your patient until they are transferred to UHL. Alternatively, the doctor may come to the ward and review the patient. They may make a medical plan and feel that it is safe for the patient to stay with us at the Bradgate unit. Ensure that they give you clear safety netting advice and a plan of care and when to escalate any concerns. This will also be guided by your news tool. However, It is likely that the patient will be transferred to UHL at this point, as indicated on your news support sheet. If the patient is scoring 5 to 6 on their news, they will be transferred to UHL if the medic hasn't reviewed them within 20 minutes. It's also important to remember that neither of the tools are to overrule the practitioner's clinical judgment. Now, if you refer back to the pathway in front of you, box 1, you've identified that there is a problem. The patient isn't looking well. They have a score of 3 or more on their news chart, or they have an increased confusion. You've moved down to box 2 and you feel that the answer to this question is no. There is no evidence or a suggestive picture of an infection. In this instance, you'd follow the flowchart up to the green box at the top of the page. This is the low risk of sepsis box. This is just helping to support you to make the clinical decision that there is a very low risk of sepsis at this point. However, this does not rule out any other concern that could be happening to that patient at that time, which is causing the increased news score or the increased confusion, or for them to feel unwell. This situation may still be critical and may still need urgent attention. It is at this point where we would recommend you follow again, return to your news trigger sheet and respond in accordance to the news triggers. If your patient is scoring, you need to be getting urgent medical attention if this is outside of their baseline exceptions and variances. Other conditions that could be presenting in front of you could include DVTs, pulmonary embolisms, gastric bleeds. There could be something developing that still needs to be an urgent response. It is important to remember that not all sick patients are going to be septic. A third of patients with a high news will have sepsis, and there has to be evidence of an infection for sepsis to be suspected. Sepsis care is also based on suspicion, and you mustn't forget the other sepsis mimics, for example, neuroleptic malignant syndrome, which is a rare but life-threatening, if not detected and treated, condition. NMS is a serious neurological disorder, meaning it affects the nervous system caused by an unusual reaction to neuroleptic medication. This is characterised by fever, muscular rigidity, altered mental status, and autonomic dysfunction. It usually develops rapidly over 24 to 72 hours and may also occur during withdrawals from antipsychotics. NMS could initially be mistaken for an infection. If we report that the patient has sepsis and the diagnosis is deemed to be NMS, that's fine. The medics at UHL will clarify anything that we have suspected, and they will not think badly of us for not diagnosing the right condition. Other areas that could mimic sepsis are pancreatitis, pulmonary embolism, as mentioned before, and heart attacks. It's important that we treat the differentials, investigate to firm up the diagnosis, which is the job of the medics and the supporting teams at UHL. So why have a screening tool at all? It enables partnership working to manage sepsis and reduce mortality. It's a universal tool, so it's simple to use and it's adapted for our area. It can follow the patient through from our service through to partner areas such as UHL. It works alongside the news support tool to help support decision making. It's a reliable identification of red flag sepsis. It will support your escalation process. Along with the SBAR tool, the news tool, and your sepsis pathway, you will have the facts and the figures, as well as what you can see in front of you when your patient is not well, to report clearly to the medics or EMAS and get the appropriate response required for that situation. Enabling prompt transfers to hospital and to continue and commence the Sepsis 6 bundle in the area that is able to provide that care. This supports the prompt action required to start the Sepsis 6 bundle. We know that it is with an hour, time critical hour, on the first presentation of red flag sepsis, which is why we are asking our medics to commence that treatment prior to leaving our unit. An additional role for the healthcare support workers or nurses within the ward area would be to ensure that any bloods that are taken at the point where the doctor is commencing the Sepsis 6 bundle are taken urgently to the blood bank, not left at reception. This is a screenshot of the public information that is shared out for the general public. These are the parameters that are shown on your news RAG system, the red, amber, green system on the back of your news trigger scores, demonstrating the aspects of red flag sepsis. Again, we are aiming to detect the patient's illness prior to it reaching these symptoms, but sometimes that may not be the case. So we're looking for slurred speech, extreme shivering or muscle pain, passing no urine in a day, severe breathlessness, feeling like they might die. Patients have been reported as saying they have an impending sense of doom, having mottled skin or discoloured skin. These are all things that the general public are being asked to look at, which also supports the rationale as to why we need to know about it within our areas of work. You have now completed the slides that contain information around sepsis awareness and the Sepsis Pathway for the Leicestershire Partnership Trust. The following slides contain scenarios which I ask you to complete so that you get the opportunity to work through the news score, plot your scores, and try and determine what's going on with the patient and what actions you would be taking whilst using your sepsis pathways that you should have in front of you. There are 3 scenarios and they're all aimed to demonstrate different aspects of the flow chart. Once you have completed these, if you could then go back to the email and complete the questionnaire within SurveyMonkey, this will then clarify that you have completed the session. Thank you for listening, and if you have any concerns or any questions regarding the sepsis pathway, please contact me. It's Jackie Moore. I am based at the Bradgate unit, and you can email me on jacqueline.moore@lespart.nhs.uk. Alternatively, you can contact the office on 295 6366. Thank you for listening.
Jane is 56 years of age and was admitted via the crisis team. Jane is very low in mood on admission, her clothes are very heavily soiled, and it is understood that she has been rough sleeping. Jane has a history of depression, asthma and eczema, although she is admitted without any medication. Jane's friend reports she has appeared confused over the last 24 hours. Ask yourself and have a think about what the possible infection risk could be here. During sessions, participants have described possible risks as being rough sleeping, asthma, chest infections, risks of pneumonia, eczema, skin infections or broken skin, and the fact that her friend has reported increased confusion. This could be overlooked as part of her mental health presentation. There could be a possibility of diagnostic overshadowing. Vital signs and symptoms. We have no baseline readings for Jane. Her respirations are 22, her oxygen saturations are 98 on room air, her heart rate is 98 and regular, her blood pressure is 105/60, her temperature is 35.6. She is alert. Hands appear very inflamed, cracked, weeping, serous and yellow coloured fluid, and are hot to touch. What actions would you take using the sepsis recognition flowchart and your news screening tool? How would you complete your SBAR?
So we need to complete Jane's news scoring sheet. Details will have been added: Jane's sticker, her name, date of birth and the day's date. We are aware that this box is very small. Her respirations are 22. Her oxygen saturations are 98. Her temperature was 35.6. Her blood pressure is 105/60. Now you need to remember, the scoring system only records the top number, which is your systolic. We wouldn't want you to plot the diastolic and accidentally score this. You do not score the low number on your BP. If you saw this written down, it would look like this: 105/60. The 105 is the systolic, the 60 is the diastolic. We only score on the systolic, which is this top number. It may be suitable to write a small arrow here so we can acknowledge the patient's blood pressure and act on any abnormalities. But for the purpose of the deteriorating patient, we are only looking at the top number of the blood pressure reading, which this would score a 1. Her heart rate is 98. And it reports that she is alert. The total score, therefore, nothing for resps, nothing for saturations. For temperature, she is scoring 1. If you can see here, you wouldn't circle this in practice. Her systolic is scoring a 1. This is a total of 2 so far. Her heart rate is also scoring 1. So she has a score of 3 in total. So the score is 3. So she's in the green aspect of the box on your RAG system on the news triggers. This requests that the nurse repeats her observations, but also that all the information is documented on the news scoring system. We've established that Jane is scoring a news of 3, and this is from three different parameters. If we are to look at our sepsis pathway and look at box 1, we can see early warning score of 3 or more. She would tick yes. Does she look unwell? Physically, we haven't been informed of that. You'd have to make that decision if you could see her. I would imagine it would be a yes. And that you have a concern with her mental state, bearing in mind her friend has reported a new, altered mental state. We're moving down, therefore, to box 2. You may only get 1 tick here, but it still indicates moving on to box 2. Box 2 is where you think about infection. At this point, we do think she has an infection due to the look of her hands, the presentation of her hands. So we can write here, yes, in her hands. We don't have to be writing any diagnosis. We're not expecting you to be medically trained. We're now moving down into box 3 to rule in or out whether this is red flag sepsis. We know that for any of these to be present on your news score, it would score a 3 in one parameter alone. This would be a news of 3, this would be a news of 3. This and this would be a news of 3. These would all alert you to a score on the news. If your alert was only to pain or unresponsive, you'd get a 3. You need to be asking when she last had a wee, and again, whether there's any risk of a delirium. We know in this circumstance that Jane has not scored a 3 in any one parameter. So the answer to this would be no. Therefore, we are going to move up to the moderate risk of sepsis box. So we are predicting that sepsis is likely, and we now need to contact the doctors. Going back to your news score, the score of 3, we're asking you for a medical review. So this can be escalated and the patient can be reviewed quite quickly. We are suspecting that she has sepsis, although there are no red flags. You can then use your SBAR tool to report this to the doctor. You can explain who you are, what ward you're on, that Jane has been admitted and you're concerned because her news score is 3. You can advise that this is in which parameters this is in within your A, B, C, D, E, that she has weeping hands, she's alert but she's not well currently, and that what you would like. I would like you to come and review her, as I think there is sepsis present and we need to act promptly. What would you like me to do? This is your evidence of what the doctor has advised you and what your actions are as a team. Your news score and triggers will also guide you with this, and they will request that you repeat the vital signs. She needs attention for her hands, and she needs attention prior to this developing into a more deteriorating condition.
Scenario 2. James is 24 years of age and was admitted to the Bradgate Mental Health Unit with a new diagnosis of schizophrenia, and he was started on a new antipsychotic. He has a history of deliberate self-harm and on admission had superficial lacerations to his forearm. Since admission, he has refused all physical health observations and any physical examination. At breakfast, James unusually declines breakfast and states he feels unwell. He says he just wants to go to have a sleep. James appears pale and appears to be occasionally shivering. He feels like he might have a bit of flu. You leave him to sleep, and in an hour you return to check him, and he appears to be unconscious. Think about some of the aspects of the scenario that could indicate a concern for James. What do you think could be happening here? Carry out a set of vital signs on James. His respirations are 28. His oxygen saturations are 91% on air. Heart rate is 130. His blood pressure is 96 systolic over 42 diastolic. Temperature is 34.9. He is alert to pain. He has an exudating malodorous wound to the left arm. What action would you take using the sepsis recognition flowchart and your news tool? How would you complete your SBAR?
So we're going to complete the news tool for James. He would have his ID sticker here. This would already have been completed. It may not be his first entry, or that, as any refusals would have already have been recorded on here. His name, date of birth, and the date of his admission, which should signify the first date on here. For the purpose of this exercise there, I'm just plotting this set of observations. So we know his respiration rate is 28, so we have to pop it in there. This means greater than or equal to 25. His oxygen levels have dropped to 91, so this is equal to or less than 91%. If we were to start him on some oxygen just now, which we would do as his oxygen levels are below 95, he would score 2 for having some additional oxygen. So you could request a member of staff fetch the oxygen and commence that. His temperature is 34.9, which again goes into this box because it's less than or equal to 35 degrees. His blood pressure is 96 systolic, so it's 96 systolic Again, I'll write it here, 96/42. This is the systolic, this is the diastolic. For the purpose of the deteriorating patient and for the scoring system, we are only scoring the top number, the systolic. We can put this down here, just so we know that his diastolic was low and for future reference. But for the scoring system, this is all we need to know. Heart rate is 130. This is on the line here. Now, to ensure that you get the right scoring system, you go down. This would be a score of 2. Because it's on the line, you don't go up, you go down. And this can be clarified if you were to look at the scoring system tool, where you'll be able to see his heart rate. Just make that larger for you. His heart rate, you come along, 130 is included in the amber section of 111 to 130. If you come back here, you can see that clarifies that you go down to score. So he's scoring 2. He is responding to pain, so you have to put to pain. Is it pain or voice? Pain. So he automatically scores 3 here. So he has a total of 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Crikey. 16, 17, 18. His score is 18. Now I think whether you were suspecting sepsis or not, by this point you would be very concerned about your patient, purely on the use of your news screening tool. Anything above 7 is an emergency. You call 999 and request medical attention urgently. So you're doing your 999 or 222. To rule in or rule out sepsis as a very quick assistance to a diagnostic, and to be able to inform your emergency call-out teams that this is a potential sepsis and potentially a red flag sepsis, this is where your pathway will support you. We know they've got an early warning score of 3. James isn't looking very good. We definitely think there's an infection due to a wound on his arm. We're looking at this, we could see that he had respirations. We only need to have one of these parameters. We know that his oxygen saturations were below 91, and he's had to have additional oxygen. We know his blood pressure was low. We know his heart rate was 30 or above, 130 or above. The scenario hasn't told us about any of these aspects, apart from the fact that he is not responding normally. He's only responding to pain. He's a very poorly young man. He's scoring a definite yes here. You'd go straight over here, and you can communicate when you do your SBAR tool for the emergency services and the medics on the ward to say, this is red flag sepsis and we need your attention now. At that point you would also obtain the black box while the doctor's on the way. You can call your 22222s and ensure that the doctors come and have access to that box whilst waiting for the paramedics to take the gentleman to hospital.
Scenario 3. Brian is a 36-year-old gentleman with schizophrenia. His BMI is greater than 30. He has sleep apnea and a history of hypertension. Whilst staying at the Bradgate Mental Health Unit, he has been low in mood and not engaging in activities, generally remaining sat in his room due to paranoid thoughts. Staff notice that he's suddenly breathing rapidly and appears unwell. They attempt to carry out a set of vital signs which he refuses. He has not yet reported feeling unwell to anyone prior to this. So Brian is refusing to allow you to approach him with any of the mechanical devices to measure his vital signs. Despite that, you're able to carry out a set of respiration rates and a heart rate manually, which he allows you to do. From doing these two vital signs, you manage to determine that his respir rate is 32 and he seems quite short of breath. His heart rate is 120 and feels irregular. It is usually 88 to 100 beats per minute and it's usually regular. Then there are no known infections. On examination, he appears to have a tender leg that appears a little bit swollen, but is stating that he has chest pain. He has been passing urine normally. What actions would you take using the sepsis recognition flowchart and the news sheet? How would you complete your SBAR?
So we're going to complete Brian's news chart. Again, he'll have his ID sticker and an award. His details have been completed at the top of the form. Any previous recordings have been added, and again, for the purpose of this video, we are just looking at the observations for this particular incident. We've put in the date and the time, and we are recording that his respiration rates are 32. Previous scores would show us that we know that this is not normal for him, and it's not normal for anybody. He's automatically scoring 3 here. Oxygen saturations, he's refused. So you could write that a bit neater. It's just difficult whilst holding the camera. His temperature, he's also refused. Blood pressure, he's also refused, both manually and with the machine, which is something that could occur in your clinical area. His heart rate, however, we have established is 120, which is on the line here. It doesn't make any difference with this one, but just for general knowledge, you would score downwards into this box, which is the same anyway, so he's scoring a 2. So just on those 2 parameters alone, he is alert. So he's not scoring anything here. But so his total on only 2 parameters, excuse me, is 3.45. BM was normal, it's 4.9. What did I say? 5. Obviously, with all the forms, you will be signing here, putting any plans, using the back sheet to document what you're doing. If you flick round to your trigger scores, he's scoring 5. So again, at this point, anything above a 3, we're asking you to think sepsis, because this can help you firm up your communication to what the emergency is. We're going to be asking, just with the SBAR, with your new score alone, for an urgent review. You're asking the doctor to come and review the patient within 20 minutes. If the doctor is unable to assess in 20 minutes and concerns remains, or a patient deteriorates further, you need to be calling your 9999 or your 2222. You want to try and rule out whether there's sepsis present or not. So we'll go to hit your screening tool, and again this will all be done quite quickly. Patient is scoring 3 or above and they're looking unwell. It's not explaining that he's confused. Now, according to the scenario and the information we have for this instance, we are saying there is no possible infection present here. You could argue that the red tender leg could be the sign of cellulitis, and if that was the case, you could always say yes and move down. But for the purpose of this, we are still determining that this either way would have been an emergency 999 call out with the score he has. So yes to this. We're saying no. We don't think he has any signs of an infection or known infection. That's what we're being informed. So we follow the pathway that there is a low risk of sepsis, but we do need to consider another diagnosis. This is just going to help you rule in or rule out the possibility of sepsis being present. And like we've said in the slideshow, there is definitely something clinically wrong with Brian right now that requires an urgent assessment. So you go back to your news school and get that urgent medical review. Don't be frightened to call 999 or your 2222s. The emergency services would rather appear to support you and the patient prior to an arrest than appear at the event that somebody has arrested. They will come and make that clinical decision for you. These services are available to you 24/7. So whether it's in hours or out of hours, you always have medical support. The suspected diagnosis here, due to the sudden onset of breathlessness, the slight tenderness and swelling of his leg, and his irregular heart rate, is a clinical indication that he might be having he's had a DVT that's maybe popped off a clot and sent that off to his lungs, and he might be having a PE, a pulmonary embolism. This is a time critical incident as well, and despite this not being sepsis, had you have decided it was sepsis, either way you would have been getting a time critical emergency response, and there would be, the response would be the same for all of those situations.